Right. Good morning, everyone. It's a pleasure to be here with you today. I hope today will be as interesting as it was yesterday. So to start us off, I'm Lorna Renner, a pediatric oncologist from Korle Teaching Hospital in Accra, Ghana. And this morning, to start us off is Helen Dimaras. She's a scientist and director of global eye health research at the Hospital for Sick Children in Toronto, Canada. She's with the Associate Professor with the University of Toronto, Scientific Advisor with the World Eye Cancer Hope, Canada. And she's going to talk to us about how social variables affect retinoblastoma outcomes. So over to Helen. Thank you. And just to say that the questions will be at the end of the session, so just hold on to your questions then. Hopefully we'll have a lot of time.
Thank you, Lorna, and good morning, everyone. Not lost on me that this is an retinoblastoma in Africa session, and only Lorna is representing Africa. So I'm going to actually take a different twist on my presentation and tell you a little bit about what's happening with social variables in retinoblastoma in Canada. But first, I wanted to just get some definitions out of the way, because as we're talking about retinoblastoma here in America, in Canada, in Africa, and around the world, social determinants are really what we're talking about. And those are non-medical factors that influence health outcomes. The World Health Organization defines 5 domains of social determinants of health. And we've already heard a little bit about this yesterday in various presentations. And the 5 domains are things like economic stability. We heard from during the cocktail reception yesterday, I heard from a very lovely couple who fundraises for prosthetic eyes for people who can't afford them. And so you can see how not having the economic means could affect how your retinoblastoma outcomes are. There's education, access, and quality, not understanding how to advocate for your own health. Healthcare access and quality. So what is the state of the hospital near you, where you live? Can you access those medical resources? There's also the social and community context. We heard so much yesterday about families not meeting other families affected by retinoblastoma until later on in their life, and think about how important that is to how you prosper with a retinoblastoma diagnosis. And then there's also your neighborhood and built environment, where you live, what your outlook is for your life. And so we don't talk about these factors often enough. And when you don't have all those social resources at your disposals, that's when inequities start to occur. And inequities are those systematic differences in health status between populations. And that's going to differ for everyone in this room and around the world. And they're socially produced. They're not medical. And so they're due to unfair and avoidable factors. And that means that we can actually create solutions that can help eliminate those inequities. And so how do social determinants of health affect retinoblastoma outcomes? We know around the world there's a survival disparity. The global cancer inequity in all pediatric cancers, there is about 95% survival in high-income countries like America, like Canada. We're very lucky. But in low and middle-income countries, many of those countries in Africa, many in Southeast Asia, there is less than 30% survival, although that's changing, and you're going to hear from some African experts in this panel that will show you how that's changing. And certainly it's not lost on me that our moderator, Dr. Lorna Renner, is really leading this initiative in Ghana. And because retinoblastoma is such a survivable cancer, the World Health Organization has listed it as a global index cancer. So there are 5 pediatric cancers that are right now a global focus of really improving things for all kids around the world, and retinoblastoma is one of them. So as much as we know and have experienced that nobody knows about retinoblastoma, that's starting to change, and there is more focus on it. So it's good that we're here and advocating together for this, and we have friends around the world supporting us too. We know also that around the world, the reason why retinoblastoma outcomes are worse when the social inequities are there, there's more advanced stage at diagnosis, and this is sometimes because of low awareness, so parents don't know what that white eye reflex is. sometimes they don't know, but they don't have Google to be able to search that, so they ignore it because it's not causing the baby pain. Sometimes there's cultural beliefs, as we heard yesterday from some of the panelists from internationally, that make people think, maybe I don't need to go to the doctor, I can go to holistic health or traditional healer. Sometimes it's financial constraints, so your child's not hurting right now, they don't appear to be having any problem, the hospital's really far away, I can't pay for the bus to get there. And sometimes there's just no available eye care near you, and you can't access that. And so what happens is kids don't get to the care soon enough, the tumor keeps growing, and there are bad outcomes. And so one of my group's initiatives to try to address one of these aspects, availability of care, is the One Retinoblastoma World map. So you can go to this at www.onerbw.org. Don't try this right now on your phone because it doesn't work on the phone. Our funding only got us to the laptop version. And right now we're updating. So all those green little dots on the map you see there are hospitals where retinoblastoma is treated around the world. And starting in 2009, we started sending out a survey to everyone we knew. The retinoblastoma community is small, and we send them a survey that says, what are the ways you have at your disposal to treat retinoblastoma? And every couple of years, we update this with the new treatment availabilities. And right now, we are updating the survey. We had a little bit of a dip during COVID and hadn't updated it in a while. So all of the medical experts in the room, you should have an email from the 1RBW team asking you to complete your profile and update any advances or losses in resources, because we know that happens as well. And so we're hoping that by end of this year, we'll have a complete picture of how retinoblastoma is treated around the world and can compare that to our prior years and see how that's changed over time. And that's just one of the ways we're trying to address one social context in retinoblastoma outcomes. In Canada, we have a really engaged retinoblastoma parent and family and survivor group that really engages in research. And a few years ago, they wanted to know what are the top research priorities, what we should be focusing on. We did a priority setting exercise where we determined and ranked actually 30 priorities. And within the top 10, number 10 is access to care. So even in Canada, where we have universal health coverage, families still understood that there's some parts of Canada, some neighborhoods you live in, some regions that just don't have all the resources necessary for retinoblastoma. And the question we all want to solve is how can optimal retinoblastoma access to care be delivered in low resource settings, including rural and remote communities. And I think this surprised us a little bit because as you see here, we're here at a session for RB, retinoblastoma in Africa, because we know, and as you'll hear later, there are some very unique challenges there. But there's unique challenges everywhere, and maybe we need to reframe how we're thinking about inequity. It's not necessarily a between borders thing. Social determinants of health affect us all. And in the States, there's been a few research projects that have shown children that live in low opportunity neighborhoods, so neighborhoods that don't have as many resources, are likelier to present with advanced stage retinoblastoma than children from high opportunity neighborhoods. So this is something we can fix, right? There's no reason that where you live should determine whether or not you have a good outcome or a bad outcome for retinoblastoma. And so we wanted to see, does this actually also hold true in Canada? We of course, have a hint at that this might be the case, but we hadn't ever looked. And this is a map of Canada, and the red province there is Ontario. That's where most of the Canadians you've met today, but not all, or this meeting, we come from the Hospital for Sick Children, which is in Toronto. An interesting fact about Canada is that most of our population actually lives across, along the border with the States, because it's so cold, we want to hug America for warmth. And, and so we set out to see what might be some of the social factors affecting how kids with retinoblastoma do in Canada. And the work I'm going to explain to you today is work that was largely done by my master's student, Omar Jamal. He just graduated with his master's, and he's off doing medical school now. And hopefully will come back and treat kids with retinoblastoma, we'll see. And what I've done here is shown you those 5 domains of social determinants of health with our little cartoon of our mascot. We've never named her. Maybe we can ask the kids in the Child Life program to name her, but you can see she's got a white eye reflex. And we wanted to know how these social factors affect her outcomes. And it's really hard to do this kind of work. We looked at the medical records as a starting place, so that means that when we're looking at the medical records, it's work that's already been, or data that's already been collected for other purposes. But we wanted to see first, do social factors or identity factors of patients affect how they, their delays in care? So are they missing appointments or canceling appointments? Are they delayed a certain amount of time? Do they have more emergency visits than other kids? And second, we want to see their actual clinical outcomes, and those that we could evaluate in large enough volume were what's their stage at diagnosis and what's their vision outcome at the end. And so the ones underlined, care plan delay, emergency visits, and vision outcome are the ones I'll talk about today. As I mentioned, it's a retrospective design, which means we went back into historical data. A more strong study would be looking at every new patient going forward. That's maybe the next thing we'll do. We only looked at kids at our hospital who were from Ontario, so we could get better data on their social characteristics. And we also looked beyond retinoblastoma. We're starting to look at other pediatric eye cancers as well. Retinoblastoma is rare, but it's the most common of the rare. And so we looked at all kids with eye cancers. Those are cancers that affect any or all parts of the eye. We're trying to engage those families as well, because being smaller groups, they have even fewer families to connect with. And so we looked at anyone in the medical record who had that diagnosis, lived in our province of Ontario, and had at least one medical visit scheduled that we could examine. We collected as many social determinants of health as we could capture from the medical record, things like age, gender, ethnic group, race, preferred language, and we used their postal code to understand indicators of which neighborhoods they lived in. Clinical data as well was from the medical record, and we looked at visit cancellations, emergency visits, and rescheduled. And we did some very simple statistics called a chi-square test and binomial and multivariable regression to see if any of these characteristics led to worse outcomes. And so our population was about 324 kids. Most, as you see here, were retinoblastoma, but we had some other tumors of the optic nerve, the orbit, the eyelid, iris, and other parts of the eye. And so because of the fact that retinoblastoma and optic pathway gliomas are our biggest groups, we really could do most statistics for them. This is what our group looked like by social demographics. So you can see the male-female is pretty much even. Ages were all sorts of ages because, of course, other eye cancers are not just in infancy. We have a race breakdown there, which is pretty representative of the Canadian population, but not complete, as well as some ethnicity variables there. Our postal code gave us which types of neighborhoods they lived in. We used something called the Ontario Marginalization Index, and this shows us in what kinds of neighborhoods, how well-resourced or poorly resourced they are. And we looked at whether they came from cities or rural areas, which region of Ontario, and how far from the hospital they lived. And so when we looked at the first one, how often were their care plan delayed, it seemed that kids that were living in rural areas, in poorly resourced areas with high marginalization in certain areas like material resources, household dwellings, and racialized and newcomer population neighborhoods, those had higher likelihood of delay. And when we looked at neighborhood income, so neighborhoods where the mean income is higher, those had less delay. And so it's not surprising, but we're seeing that these inequities exist in our population. When we look at emergency visits, we also see that living in highly marginalized neighborhoods and being of a non-white race. The reason why we grouped these racial differences was because we have a small group and we couldn't look at each one individually, so I know that's that is a limitation of our study. Those were linked with high emergency visits, and again, living in a high-income neighborhood had fewer emergency visits. And then I'm just showing you the visual impairment with bilateral RB. Again, living in a rural neighborhood, in less marginalized areas, and more marginalized areas led to worse vision outcome, and high-income neighborhood was linked to better vision outcome. And so, as I mentioned, there are some limitations to this study. The neighborhood data is not always reflective of individual data. We didn't have individual data, and you can imagine a scenario where maybe a child lives in a low-income neighborhood, but actually is from a high-income family. It's a retrospective study, so we didn't get to collect this data for the purpose of this study. And the study method implies an association, but we don't really know what the causation is. But still, it gives us a first hint that social variables and social inequities are present in Ontario, and we need to do something about them. And so one way we can move forward is to start screening for some of these risk variables, to understand better the populations we're serving, and come up with interventions that might help them do better. Some other areas are beginning to give social prescriptions. So if you can't get to the hospital because you can't afford the transportation fare, you get a prescription for an Uber ride or a bus token. And so there's additional research we need to do to tease out how those social variables affect health outcomes. I was inspired to do this work because of the work I have been privileged enough to do in Kenya with colleagues, but I felt that that work is better described by them, and this is why I chose to talk about Canadian factors in the retinoblastoma in Africa panel. So thank you for your attention. These are some acknowledgements and my lab back at Sick Kids and our Sick Kids retinoblastoma program. Thanks very much.
Thank you very much, Helen, for that very informative talk. And I just missed out. Welcome also to those online who are listening in to this session. You can see there are very few panelists. Unfortunately, as happens, most of the speakers, for one reason or the other, couldn't make it from Africa. But we have pre-recorded talks. So our first pre-recorded talk is a combined joint talk from Ifeoma Ezegwui from Nigeria. She's a professor of ophthalmology in Enugu, and she's a consultant pediatric ophthalmologist, University of Nigeria Teaching Hospital. She's talking together with Ifeoma Chigozie, also a consultant ophthalmologist, Department of Ophthalmology, University of Calabar Teaching Hospital, Calabar, Nigeria. And they are going to talk about the state of retinoblastoma in Nigeria. Thank you. I hope we're ready? Yeah.
I'm Professor Ifeoma Ezegwui. I'd like to express gratitude to Marisa Gonzalez for allowing my colleague, Dr. Ifeoma and I to make this presentation on the state of retinoblastoma in Nigeria. We'll make our discussion using this outline. Retinoblastoma is the most common intraocular cancer in children in Nigeria. Our country, Nigeria, is located in the west coast of West Africa. It has an estimated population of 218.5 million and is the most populated country in Africa. These are our hospitals. Dr. H is of the University of Calabar Teaching Hospital, Calabar, and from University of Nigeria Teaching Hospital, Ituku-Ozalla, Enugu. The incidence of retinoblastoma in Nigeria is 196 cases per year. The Global Retinoblastoma Study estimates that children in low and middle-income countries with retinoblastoma are diagnosed at a median age of 30.5 months. 49.1% present with extraocular disease. 18.9% present with metastatic disease. Our country is divided into 6 geopolitical zones. Dr. H works in the South-South Nigeria. that is in blue color, and I work in the Southeast Nigeria in the yellow color. This slide shows the average age at presentation, at hospital presentation of children with retinoblastoma. In the South-South region, they present at an average age of 25 plus or minus 9 months. And in the Southeast, they present at 24 plus or minus 4 months. The unilateral mode of presentation is the commonest pattern of retinoblastoma presentation in our country. This is followed by the bilateral presentation, and the least common is the trilateral presentation, that is involving the two eyes and the pineal gland. Studies done in different parts of Nigeria show that the commonest mode of presentation is late presentation. That's orbital disease and metastatic disease, that the leading mode of presentation. These are pictures showing some of the late presentation we see in our country. And even when they present as intraocular disease, as the picture on the left and on the right, presentation is still late because the anterior segment already is invaded with Ifeoma in the anterior chamber. There has been a changing pattern in the mode of presentation of retinoblastoma in recent years. Like this work published by Korle et al., they noticed that orbital disease and metastatic disease have been on the decline, while intraocular presentation has increased. Like proptosis declined from 55.5% in 2013 to 10.7% in 2019. DOHAS is a major referral center where people that have children that their retinoblastoma is such that the globe can be salvaged are referred to her center, so the study may be a bit biased. This is some of the early presentation. A good number of intraocular diseases still do not present early enough for globe salvage. So enucleation is still commonly offered to children with retinoblastoma. Looking at the ancillary diagnostic tests we have in Nigeria, B-scan ultrasound is generally available and also affordable. MRI and CT scans, they're available, but our health insurance is not quite effective and patients have to pay out of pocket. So many of them do not utilize this service even when it's available. Pathology services are generally available in most tertiary institutions, but the pathologist may not have received a focused training in ocular oncology. Molecular gene testing is generally not available in our country. Looking at the treatment options for retinoblastoma in Nigeria, several tertiary centers in Nigeria offer different levels of care for retinoblastoma patients, but only one center is fully equipped for globe salvage. The intravenous chemotherapy with first-line drugs, that's vincristine, etoposide, and carboplatin, are generally available in most teaching hospitals, though patients pay out of pocket. Intravitreal chemotherapy is available in a few centers, mainly topotecan. Laser photocoagulation and cryotherapy are available. Intraarterial chemotherapy was very recently introduced, only last year, and only one center currently offers it, but cost is still a setback. External beam radiotherapy is available in a few centers. Plaque brachytherapy is not available. Most teaching hospitals are able to offer enucleation services, but few have ocular services. Like this child had a proper ocular service post-enucleation.
I will go ahead to talk about the steps in improving retinoblastoma outcomes in Nigeria. Early diagnosis is key for treatment of retinoblastoma. At the goal of improving retinoblastoma outcomes, we are grateful to receive Hope Foundation for donating 50 Life ophthalmoscopes early this year to world to train community health workers on screening of under 5 children for fundal reflex. This is a picture showing the process where we train the community health workers during immunization. So currently, the community health workers are screening for good fundal reflex in children. Also, the Know the Globe Foundation partnered with us to increase efforts at public health awareness. This was done throughout 3 months in the year. It's also worthy of note to point to the fact that Dr. D.B.Ch.B came with his team to perform the first intraarterial chemotherapy treatment for retinoblastoma in Nigeria in 2023. And we can see a picture showing the increased number of trained ocular oncologists in Nigeria converging at Mombasa, Kenya last year for the first ISO Africa to deliberate on outcomes to ways to improve retinoblastoma outcomes. In addition, we've had links for collaborations, ongoing link collaborations with the RB-MET NBC meeting, which has improved clinical outcomes generally for the management of retinoblastoma in Nigeria. These are the pictures. Further pictures is being seen here. Currently, we are trying to develop a national retinoblastoma program. This is still an ongoing process with negotiations with key stakeholders in the country. Although Nigeria is yet to attain universal health coverage, chemotherapeutic agents for retinoblastoma have been included for insurance coverage, and this is a positive step for retinoblastoma management in Nigeria. The National Strategic Cancer Control has a strategic plan for 2023 to 2027, and one of its objectives is to increase the number of trained pediatric oncologists and ophthalmic oncologists to provide services in Nigerian hospitals by 2027. We deliberate efforts at public health education, institutional training at all levels of healthcare. We are currently experiencing a positive paradigm shift in the management of retinoblastoma with better outcomes, as seen in the report by Korle et al., where early presentation has increased from 22.6% to 85.7%. This is a major referral center and the only center that currently offers low salvage. Nigeria is a large country and densely populated, as we had already said, and we have very poor transport network. It's expensive and challenging for patients to move from one part of the country to another. So establishing a few other centers can help us offer group salvage. This is an ongoing process and we are working on it. Collaborations with other centers in high-income countries will lead to training and retaining of pediatric ophthalmologists, ocular oncologists, pediatric oncologists, as well as ocular pathologists to improve capacity to manage retinoblastoma in our country. We'll be happy to partner with everyone to achieve better outcomes for retinoblastoma patients so that we can also say strongly the live and the see. These are our references. Thank you once more for inviting myself and Professor Ifeoma Ezegwui to give this presentation at the One Retinoblastoma meeting. Thank you.
Thank you very much, the two Ifeomas from Nigeria. Thank you for that very informative talk. So next, we have a pre-recorded talk from Didi Fabian. He's an associate professor with the London School of Hygiene and Tropical Medicine. He's an ocular oncologist and currently the director of Sheba Global Ophthalmology, Sheba Medical Center in Israel. And his talk is a recap of International Society of Ocular Oncology in Africa. So, yes, Didi Fabian, thank you.
Good morning, good afternoon, good evening, everyone. It's an honor to present here at the 1RB World Meeting. My name is Didi Fabian, and unfortunately I could not make it in person, but I'm grateful for the opportunity to connect and share my experiences from across the globe. Today I will discuss the journey in making and execution of the first ISU conference in the African continent, which took place in Mombasa, Kenya, last August. ISU is a nonprofit organization dedicated to advancing and promoting ocular oncology globally. In the 1970s and 1980s, there were very few ocular oncologists worldwide. Most patients with eye tumors were treated by general eye doctors or other specialists with limited education for ocular oncology, mainly through a few paper or poster presentations. Today, ISO's mission is to promote the advancement of ocular oncology by encouraging research, fostering international collaboration, and most importantly, prioritizing education. As you can see, the majority of members are from North America, Europe, and few from Asia, with very few members coming from Africa. If we combine all the members from high-income countries, they make up over 80% of our total membership. That's the directory. Interestingly, the distribution is the mirror opposite of the global distribution of RB cases. As you can see, only 15% of these cases occur in high-income countries. Furthermore, there is an international ISO conference held in countries across the world every 2 years, but it has never taken place in Africa. The distinctions are evident in numbers, how they're presented, their treatment capacities, and naturally their outlook for recovery. This inspired us to act and shift focus on Africa. In March 2022, during the ISO conference in Leiden, the Netherlands, I approached Dan Gambas, the ISO president, with the vision of having a first ISO Africa conference, a formal ISO-supported conference in Africa, and he graciously gave us his blessing. Next, we formed the team, including Dr. Kahaki Kimani, an ocular oncologist from Nairobi, Kenya, who graciously agreed to host the conference in her home country, and Dr. Laurence Desjardins, who had extensive experience in eye oncology at Institut Curie in Paris, and for a long time is actively supporting Francophone, but not only Francophone, also Anglophone Africa through an NGO called M.P.H, and they both joined the team. The conference was scheduled 2 days before COEXA at the same venue to ensure attendees could easily participate in both events and foster collaboration. In total, we had over 200 participants from 43 countries around the globe, with nearly half of them representing African nations, as you can see. Seeing so many African colleagues gathered in one place, sharing their clinical insights and research findings was truly remarkable for me. As you can see here, 15 of the countries were outside of the continent of Africa. The diversity in geography and culture at this conference was really astounding. 90 abstracts were submitted to be presented, with most of them coming from Africa, the rest from 13 countries across the world. The conference spanned 3 days. On the first day, we delved into scientific collaborations, pathology, and attended a workshop led by the M.P.H NGO. The second day centered around the theme of ISO Africa. We hosted an official symposium on retinoblastoma where representatives from each African country presented their national data on RB, highlighting diverse presentations, treatments, and of course, outcomes. The third day was dedicated to other tumor pathologies, including OSSN, ocular surface squamous neoplasia, which is very common in Africa. We decided to collaborate with many organizations as well as establish task forces to plan the conference. For retinoblastoma, I must thank Dr. Popula from Nigeria, Matt Wilson from the US, and Vera Esseman from Ghana, and a very big thank you to Dr. Jesse Berry from LA, USA, who was a real supporter for this entire initiative. One of the conference highlights was Morgan Livingston's insightful presentation on social support and how to approach kids who must unfortunately undergo enucleation. Michel Ungaro, a bilateral retinoblastoma survivor and a professional musician, spoke about his son that he lost to RB and sang us a song he wrote about him. Marisa Gonzalez, president of We See Hope USA, herself a survivor of RB, shared her personal journey and advocated passionately for the cause. At the St. June workshop, groups organized by language, Portuguese, Spanish, English, French, discussed RB treatment in Africa using a structured work chart. We identified common weaknesses such as economic burden and lack of specialists, but were inspired by our shared strength in multidisciplinary care and telemedicine advancement through initiatives like the RBNet at the London School of Hygiene and Tropical Medicine and others. The workshop was highly successful, showcasing genuine collaboration among physicians, healthcare professionals, social workers, non-profit organizations, NGOs, and various stakeholders dedicated to advancing RB treatment in Africa. We held a session featuring today's leading technologies from around the world, presented by global leaders in the field, as well as a gathering on women in ocular oncology. We had very inspiring keynote lectures from Dr. Brenda Gali at Sick Kids, who said Africa will level the playing field for children with retinoblastoma. Dr. Carol Shields over Zoom at from Wills Eye Hospital, who has trained many of us today. Dr. Francis Munier from Switzerland, who helped shape the intraocular chemotherapeutic treatment of RB. And Dr. Chiku Matenge, director and co-founder of the Rwanda International Institute of Ophthalmology. I want to express my gratitude, my sincere gratitude to our conference supporters whose contributions made this event possible and truly impactful. And want to extend a special thank you to Abby White for her outstanding contributions to advancing advocacy in retinoblastoma. The conference ended with a dance party with representatives from all over the world, Africa, Asia, North and South America, Europe, all together, embracing the hardship but commitment for ending RB mortality. Under the stars of the city of blue and white, that is Mombasa. Overall, the first ISO Africa conference was a journey filled with challenges and tremendous rewards. I owe immense gratitude to my inspiring colleagues for their support. I'm optimistic that this conference will not only enhance retinoblastoma care across Africa, but also forge strong relationships, collaborations, and networking opportunities for sharing research and innovation related to RB. The next ISO conference is taking place in Goa this upcoming December. Thank you for this opportunity.
Thank you very much, Didi, for this very interesting and colorful presentation, very accurate presentation about the first ISO conference in Africa. Thank you. So our next presenter is M.B.Ch.B, a retinoblastoma parent in Addis Ababa, Ethiopia. And M.B.Ch. is going to talk to us about raising a child with retinoblastoma in developing countries. Thank you.
Hi, everyone. My name is Dr. M.B.Ch.B from Ethiopia. So I am a father of a son who is now 14, and he is a survivor of bilateral retinoblastoma. So I'll be sharing my experience as a parent of raising a baby or a child with retinoblastoma in one of developing countries, Ethiopia, and I will also be sharing the situation that we are having in our context. So first of all, I would like to say for the conference organizers for giving me this chance to present my experience as a parent. I should have been there in person, but due to financial limitations, I am forced to present virtually. So thank you again. So my presentation will be on retinoblastoma experience from Ethiopia. So as you are aware, retinoblastoma is one of the most common pediatric cancer cases worldwide. And so incidence of retinoblastoma has been estimated around 8,000. And the mortality rate, it varies in higher income countries and low and middle income countries. So, but annually the mortality rate is reported to be greater than 3,000 children, but it varies between the two groups of countries. So in lower and middle income countries, it is higher than those in the higher income countries. So concerning the global retinoblastoma population, the 28% is contributed from sub-Saharan Africa, which is Ethiopia is part of this part of region. So you can see the burden is very high in our context. So coming to the Ethiopia, well, relatively there is some attention given recently from medical professionals, but not that much. We need to work more on that area also, because sometimes diagnosis is missed or is not properly diagnosed at a general hospital. So there is better attention, but again, it needs further work in this regard. So fewer cases are reported in our context. So the cases reported are still insignificant. For example, in 2017, 91 cases were reported. In the next year, 53. And in 2019, only 62 cases were reported. So you can see that still insignificant cases were reported to health facilities. Even those reported to health facilities were not detected early, so late detection and late treatment was an issue. And that's why we're having like 40.1% extraocular retinoblastoma in Ethiopia reporting. So it is huge number, which probably will increase the mortality rate due to this late detection or late treatment of this particular retinoblastoma. So the delayed presentation, late stage at diagnosis. So overall, one research conducted in Ethiopia indicates that the lag time from noticing the first symptom to treatment was 14.31 months, and the range is from 0.25 to 62.25 months in Ethiopia. So 14.31 months is an average lag time from noticing the first symptom to treatment in our context. So due to this and other factors, the mortality rate is close to 47%, which is actually a big number compared to those mortality rates in higher income countries. And we have some reasons as to why the mortality rate has increased, including lack of awareness about retinoblastoma is one issue. The cost is another issue, and travel distance, because health facilities that give this kind of service is found in urban places, and travel distance from rural to urban is a bit expensive and is not convenient for parents. So due to this and other factors, parents were having intense mental distress, particularly RB caregivers, which suggests that the need for psychosocial support and care, even for parents rearing this kind of children with retinoblastoma. So what are the challenges in retinoblastoma management in Ethiopia? The first is health care infrastructure. So we have limited pediatric oncologists and cancer centers. That is one limitation that we're having. Geographical access, as I have said earlier, is another issue. So the healthcare infrastructure as a whole is a challenge in our context. Financial constraint is another issue, particularly to get access to treatment areas. Referral hospitals is another issue, because if they travel from rural to urban areas, they need to have some kind of cash to run their daily life. So that is one issue that we are facing in our context. Cultural and awareness barrier is another issue. So the stigma is there still, stigma discrimination is there. And sometimes they consider it as a punishment from God, or it is due to the sin of parents. So cultural issues are there. So late referrals is another issue that we are having. Again, we have a difficulty of accessing artificial or prosthetic eyes for children whose eyes have been inoculated to prevent the spread of the cancer. So difficulty of accessing prosthetic eyes is another challenge in Ethiopian context. And we don't have support groups on retinoblastoma. We have started some, we're actually on the way to establish support groups, family support groups, but we don't have so far. So this is another challenge in managing retinoblastoma in Ethiopian context. So the challenge of parent caregivers, as I've said earlier, stigma and discrimination is one issue. Associating such cases as punishment of God due to evil eye or due to the sin of parents is commonly experienced in our context. So due to the stigma and discrimination, most parents, they keep their children at home and they don't have the strength to take their children to public places, including to hospitals. So that is why we're having high mortality rate, because cases are not reported to health facilities. Socioeconomic impact is another challenge of parents. They lose their job to take care of their children. They sell their belongings, and they do have actually weak social networking. So retinoblastoma has some socioeconomic impact on parents or caregivers. So due to this and other factors, parents are experiencing significant mental health and psychosocial burden, which needs to be actually, it needs some intervention in the future. So next I will be sharing my experience as a parent. So I'll be telling you about my son, whose name is Bisrat, and born in 2009, and he is actually my firstborn. But around 3 months, my mother and my mother-in-law, they observed some unusual eye movement as he is not following hand directions, hand movements. So they say we need to take him to hospital, but we said, or other members of the family said, well, he's not crying, he's normal, why do we take him to hospital? So actually, we took him to the M.P.H center where he was born, and the doctor said he's fine. Within months, it will be normal. It will start to follow. There is nothing that makes you worry about his eyes, so he's normal. But repeatedly, my mother and my mother-in-law were asking to get, second opinion in one of the eye hospitals in Ethiopia. So we went to Minilik Second Hospital Eye Unit. So retinoblastoma case was identified. Unfortunately, it was bilateral retinoblastoma. And I remember that the doctors have been afraid, and there is a difficulty of breaking the bad news. So they didn't manage it well. That is one challenge that we have passed through. And another challenge that we faced is we have been, generally you can say in Ethiopia, we have an extended family members. So there has been some resistance from families regarding the planned medical treatment, that is inoculation or removal of eyes. So why we need to take it to other treatment, traditional or religious treatment, why removing eyes? He's not crying, he's normal. They have been saying that. So that is one challenge that we've faced. So as a parent, at that time, the only option that we have in Ethiopia is inoculating both eyes to save his life. But we have been looking for other alternatives, and fortunately, we managed to get in contact with Daisy Eye Cancer Fund from Kenya. So we traveled to Kenya for the treatment. So actually, we have been there for 3 months, and we got his medical treatment at Kenya International Hospital. Well, we tried our best, but the treatment was not successful, the chemotherapy, to save his sight. But we managed to save his life, which we are happy. And we have a beautiful story to tell him how we went through all these procedures. At least, we are happy that we have saved his life, but unfortunate that we couldn't save his sight. So both eyes were inoculated at Kenyatta National Hospital. But Busrat is actually a very brilliant RP survivor, having a bright future. He's now 14, high school student. He is one of top performing students so far from his school, and has received different recognitions for his academic achievement from his school, from sub-city level, from city administration, where we are living in Addis Ababa. So he's one of the top performers at city level, and he's the first one in scoring national exam results from those with disabilities. So he's having a bright future, I can say, and he received actually a short-term scholarship for German language training at Bamberg, Germany, from Goethe Institute, and he traveled there for 3 weeks. He is now back in Addis. And actually, we have managed, to share his experience on TV stations, well-known national TV stations, on radio programs, as well as he has been on Kids magazine. He shared his experience, his capabilities, and other things on Kids magazine. So we have created a mentality that say, I can do with little support. So we give him actually little support, but he tries everything by his own as far as there is no safety issue. So he can play football, he can play piano, krar, which is one of local music instrument. He does bicycle. Bicycling is another favorite activity of Busrat. He plays mobile games with his brothers and siblings at home. Yeah, actually, he does a lot of things by his own, because he feels that he's capable of doing. We only show him with little support. So in the future, he wants to study law, and he has interest to advocate rights of people with disabilities in Ethiopia, because we have so many challenges for such group. So these are some of the pictures of Busrat while receiving recognition at school level, interviewing on radio station and TV station, with one of the famous distance run, Haile Gebrselassie, after running with other kids while riding horse. So these are some of his pictures of Busrat. So to conclude, the way forward is we need to improve awareness of the public at large regarding retinoblastoma, the symptoms, the signs, so that we can be successful in early diagnosis and early treatment of RAB cases in Ethiopia, because the mortality rate is still high in our context. Establishing family support group is another issue. We have started it, but we need support from others to establish the family support group. That will be another priority. And early detection and treatment of RAB cases is another issue that we need to work on. So this is the case that we are having, the situation that we're having in one of the East African countries, Ethiopia. And thank you very much. Thank you. I really appreciate the chance given me to present my experience. Thank you again.
Thank you very much, Emas. This was a very inspirational real-life experience that despite all the limitations, so much can be achieved by survivors. Thank you. I know we've gone a bit beyond time, but I think it was worth listening to this talk. Thank you so, so much. Our next presenter is Anne Ampar Musika. She's from the University of Kampala, Legon, Uganda. Makerere University, Kampala, Uganda. She's an oculoplastic surgeon and ocular oncologist at the Mulago National Referral Hospital and Uganda Cancer Institute. Her pre-recorded talk is on retinoblastoma in Uganda, strides and setbacks. Thank you, Anne.
Hello, everyone. My name is Dr. Anne Mpire Musika. I'm an orbits and oculoplastic surgeon and ocular oncologist working with Makerere University, Mulago National Referral Hospital, and Uganda Cancer Institute. Today, I would wish to talk to you about retinoblastoma in Uganda, its strides and setbacks. Uganda is found in East Africa. It's also called the Pearl of Africa. It has a population of 45.9 million people, 50.5 of whom are below 18 years, and 73.2 are below 30 years. The fertility rate is at 4.3 births per woman, and the infant mortality rate is at 38 per 1,000 live births. There are 2 treatment centers for retinoblastoma in the nation, which include Mulago National Referral Hospital, working with Uganda Cancer Institute, and Ruharo Eye Center in southwestern Uganda. Ruharo Eye Center is a missionary hospital that was established in 2006 with Dr. Keith Waddell. Over 1,600 retinoblastoma cases have been seen since then, and chemotherapy started in 2009. So before that, it was majorly enucleation and exenteration. Laser and cryotherapy have also gotten on board with the years, and right now, a lot of globe salvage is being done at Ruharo Eye Center. Annually, over 120 patients are seen. Uganda Cancer Institute, situated in Kampala, is a regional center for excellence in cancer care and offers adult and pediatric oncology services. Retinoblastoma care started in 2015, and this was majorly chemotherapy and radiotherapy. And it's external beam radiation that is offered for radiotherapy. 40 retinoblastoma patients are seen annually at this facility. Mulago National Referral Hospital works with the UCI in line with eye care. It has an established ophthalmology department with 2 pediatric ophthalmologists, 1 ocular oncologist, and 2 orbitosurgeons. It offers 3 theater days per week with general anesthesia, and here free surgery and EUA follow-ups are offered for the retinoblastoma patients. Great strides have been made at Ruharo Eye Center, and these include manpower, where they have a pediatric ophthalmologist and a team that is well skilled over the years to manage the retinoblastoma patients. They offer globe-sparing services, which include cryotherapy and laser therapy, on top of the intravitreal chemotherapy and intravenous chemotherapy. At Ruharo Eye Center, patients and their caretakers are offered accommodation and food. There is a very good follow-up system at the Ruharo Eye Center, where patients are tracked up to their homes and they have the contacts of who to contact in case they are not available. This has been facilitated with the partners and funders that they have secured over time. And there has also had an increase in the coverage for this facility, that patients come from DRC Congo, South Sudan, Northern Tanzania, Kenya, Burundi, and Rwanda. Uganda Cancer Institute has also made some strides, much as it started later, by providing ocular oncology space in pediatric oncology department, which will enable coordination of services at the unit. It also has a retinoblastoma tumor board that was established, and this includes pediatric oncologists, pathologists, ocular oncologists, radiologists, radiation oncologists, and ped oncology nurses. It also has a CT scan available only at a fee, though, and it established a baseline study, which is to help in the monitoring and evaluation of the unit's performance, as well as for future improvement as a reference. UCI also has the laser and cryo machine that have been secured but are yet to be put to use, as they will soon be assembled. Despite making many strides, Ruharo Eye Center still has setbacks. One of them is late presentation of the patients. They also have increasing numbers of retinoblastoma cases that might challenge their capacity over time. There is no RETCAM to generate evidence of the disease that is necessary for follow-up. There is no CT scan or MRI. They have a challenge of costs for staffing and inadequate funds generally for other things. There is inadequate patient support as the numbers increase over time. Uganda Cancer Institute has had some setbacks, and these include late presentation of the patients. Most of them present late. A good number of them have abandoned treatment, and this is majorly because of lack of patient support in terms of counseling, in terms of financial support, social support, and there is limited follow-up. There is no established follow-up system at the UCI. There are no reliable contacts generated from the patients, and this is majorly because of limited funds. There is also no RETCAM that is useful for generating evidence and as for it's needed for follow-up of these patients. And overall, there is limited partnership as far as retinoblastoma care is concerned. The only partners that have been there have been AMCC and St. Jude Global that facilitated some training and also offered some equipment that are relevant in retinoblastoma treatment. Mulago National Referral Hospital has a multiplex of challenges. It being a government facility and non-paying at that, has limited funding. There is no user fee for sustainability. There is no laser therapy machine at the moment and no cryotherapy, despite having well-trained personnel that would be ready to work on the retinoblastoma patients efficiently. There is lack of partners in retinoblastoma eye care. There is limited social support for the patients and their caretakers, and there is lack of genetic services. Much as there is desire to develop in research and care in terms of genetics, there is still a limit on what can be done. There is lack of funds for raising awareness and training. Having known that most of our patients come late, our desire is to raise awareness in the communities and amongst health workers, but we still lack in this area. However, not all hope is lost. Much as our children come in late, only in time for enucleation, we are able to put a smile on their faces as we offer them artificial eyes. We have some donated orbital implants and prosthesis that we can offer them. We also have an ocularist who is interested in making some custom-made prosthesis for those for whom the other general prosthesis do not work. I want to thank Marisa Gonzalez for inviting me to present, and Eye Health Africa for coordinating and connecting me to Marisa. We also want to thank RBNet MDT that helps us in discussing some of the tumor retinoblastoma cases that are complex, and AMCC for the coordination and training and the equipment provided to enable retinoblastoma care start at the UCI. We also thank St. Jude Global for coordination of training for the eye care workers as well as the other oncology team at the UCI. Ruharo Eye Care Center has also had a good number of support from John Peter Medical Foundation, Chisen Foundation, Amoa Onlas Fund, Ulverscroft Foundation, and CBM. All these efforts are highly appreciated. Thank you very much for listening to me.
Thank you very much, Anne, for presenting the informative situation in Uganda. Now it's my turn, Lorna Renner, talking to you about the journey towards improving outcomes for children with retinoblastoma in Ghana. So let's go on, please. Oh, sorry. Is it this one? Yes. So this is my outline. It's one of the retinoblastoma is one of the commonest ocular tumors in Korle Hospital where I practice. Unfortunately, as other speakers have stated, many of the cases present quite late. And it's the third commonest childhood malignancy in my hospital after leukemia and lymphomas. We see about 20 to 25 cases a year in my hospital and 65 to 70 cases in the rest of the country. And it accounts for 2% of childhood deaths from malignancies in autopsy studies in Ghana. These pictures just show some of the presentations. Overall survival, unfortunately, is less than 50% because of late stage and 56% abandonment of treatment due to various reasons, cultural, lack of knowledge, and fear of enucleation, etc. Before we started this, there was no comprehensive center, and there was no national program for retinoblastoma, and funding was a challenge. So the journey began really in 2017 during the One Retinoblastoma World Conference in Washington, D.C. The dark lady at the back is Vera Isuman, one of our pediatric ophthalmologists, and you can see Brenda standing there. And it reinforced the conviction to start a national strategy. And Vera and myself started networking, and we received some assistance. Our major partner was the Himalayan Cataract Project to kickstart this. Okay, so we needed to establish a national strategy for retinoblastoma management with the goal to improve on medical care, mobilize resources, conduct collaborative research, monitor and evaluation, and improve survival to at least 60% in 5 years, in line with the global WHO Global Initiative for Childhood Cancers, at least 60%. And so our first goal, is to improve medical care. What have been the major achievements? There's development of a national steering committee for retinoblastoma and retinoblastoma care team. The strategy has been developed, and there's been establishment of new treatments and services. So focal like laser and other local treatment, intraarterial chemotherapy, that's now, it's been in operation since the year 2020. And we've done about almost 20 children with intraarterial chemotherapy. Then we also are able to offer intravitreal chemotherapy, and we're starting periocular chemotherapy as well. And we've also got retinoblastoma pathologists trained as well. And we have active stakeholder engagement, both local and international partners. Still on improving medical care, is important early detection. So newborn and early childhood screening is ongoing, and we've trained health workers. It's important to train the health workers. As you can see from other presentations, they cause delays on early warning signs and symptoms. And there's a short code stroke app for referrals. And there's been external trainings, as stated earlier, in retinoblastoma pathology, in ocular oncology, and interventional radiology in various places in Canada, in the US of A, and in India, and also in Beijing, China. Okay. So this shows one of the charts that is used in training in the regions. And the training is also done in combination with earlier warning signs and symptoms for other childhood cancers. We can't take retinoblastoma sort of separately from other childhood cancers. With regards to mobilizing resources, we've succeeded in including retinoblastoma on the National Health Insurance coverage in November 2021 with advocacy, major advocacy from our First Lady. She was quite instrumental on that, and other stakeholders as well. And so like things like surgery is covered, but still for chemotherapy, parents still have to pay for some aspects out of pocket. So there's still ongoing fundraising and advocacy, and we use patient stories to help with our advocacy. And we're establishing an endowment fund so that no child who presents and no family has to be impoverished by having to pay for treatment, or no child should be turned away. With regards to collaborative research, a baseline national survey on retinoblastoma was completed in 2021. We worked together with SickKids Toronto, and Helen Dimaras was quite instrumental with that. Thank you, Helen. And we've just had one publication now. That's the minor publication. The major one on epidemiology is still, we're working on that to come out. The publication that has come out is on factors affecting delays to treatment with children with retinoblastoma. And the next point is, it's not really collaborative research, but just to show where we've got to as well. With collaboration with AMCC, we've started training ocularists from other countries in Accra. So we've got a good ocularist on our team. Thank you. Goal 4, monitoring and evaluation. I know monitoring and evaluation has to do more with data, which we're still working on, but just to say that the multidisciplinary retinoblastoma care team has its own meetings in addition to participating in the general pediatric oncology tumor board, and also they participate in the RB Net MDT virtual meetings as well. So what are our next steps? Next steps is to strengthen the referral pathways. We have been using the short code, but those who developed it, there have been some issues over the past few months which they're sorting out, and hopefully we'll get back to using that because that was very helpful in alerting us to referrals and following up on those referrals. And we need to complete our guidelines to also include genetic counseling, which is very important, as was raised yesterday. And we also need to really improve data collection, establishing our registry for retinoblastoma. Capacity building is obviously ongoing, including equipment and supplies. And we should continue to improve on our interventions for early detection by starting, and also for new treatments as well, by including brachytherapy, where what has been limiting has been the permission to import the radioactive plaques. That's the rate-limiting step. But hopefully, beginning of next year, we'll be able to get those in, and we'll be able to get training from Aaron Singh in the USA. He'll be coming over to train us on that. And the endowment fund, we need to complete all the necessary official processes for that. So these are my references, and appreciation to all of you, One RB World organizers, and all those we've been working together with. And I was asked also just to mention a bit about AORTIC. AORTIC is the African Organization for Research and Training in Cancer, with a mission to transform cancer control in Africa through collaboration in education, research, and delivery of equitable and timely interventions to minimize the impact of cancer. And its vision is Africa, a continent where all have universal access to cancer care. And the current president of AORTIC is M.B.Ch.B, and the incoming president is Ceciltina Lorenzo, Miriam is from Kenya, and Ceciltina is from Mozambique. And they have vice presidents from the 4 parts of Africa, North, South, East, and West Africa vice presidents, as well as vice president from Europe and a vice president from North America as well. And we have meetings once every 2 years, and there are various educational programs and assistance with research for teams in Africa. And our next meeting will be in 2025 in Tunisia under this particular theme. So that's a bit about what's going on in cancer research and training in Africa, aortic. Thank you very much, my presentation. Okay, so finally, our last presenter. I think we're back on time now, yes. Our last presenter is Andrew Stacey. He's an associate professor and division director, ocular oncology, University of Washington, Seattle. He's an associate director of medical student education for research in the Department of Ophthalmology, University of Washington. And he's going to talk to us about retinoblastoma in Africa, past and present, past and future. Yes, thank you, Andrew.
Thank you all. I'm tall. Thank you all. I am grateful to be here, and thank you to the organizers. Thank you especially to Marissa. I didn't meet any of the deadlines to get anything submitted, and she was gracious enough to work with me. Thank you. Thank you so much. My name's Andrew Stacey. I take care of the kids with retinoblastoma in the Northwest in Seattle. And I'm going to talk today about some of the work I've been working with on a number of the people you've heard today and some other analyses. I'm going to try and paint a picture for retinoblastoma in Africa now and a potential opportunity for us to be aware of for retinoblastoma in Africa in the future. I'm supposed to press the green button. It is not, oh, there we go. We've talked already about retinoblastoma. It is the most common eye cancer, in children, and very common cancer in children in general. About 5% of all cancers are retinoblastoma in children. We also have heard that the outcomes in high-income countries are better, on average, than the outcomes in low-income countries. I'm going to show some of the same photos that you've seen, and I'm sorry if they're upsetting, but these are 2 patients from a study that we're going to talk about, the patient on the left from a high-income country and the patient on the right from a low-income country. We knew for many years that the incidence and the outcomes were different between low-income countries and high-income countries, but we wanted to understand a little bit better about what those differences were. You've heard references to the global retinoblastoma study. I'm going to talk a little bit about that, but then I'm going to focus on 2 analyses from that study that have recently come out that help to paint a picture for what retinoblastoma is going to look like in the future in Africa. In 2017, we set out to try and understand what the actual difference was between retinoblastoma in low-income countries and high-income countries. We did that by following patients who came to the hospital. And we took information from them when they came to the hospital in 2017, and then we looked at their information 3 years later in 2020. Briefly, in 2017, we recruited as many people as we could. As you've heard, the retinoblastoma community is small, and we all are very collaborative, and once everybody heard about this going on, most people in the world wanted to join. And so really, to join, all you needed to do was take care of patients with retinoblastoma, and you were part of the study. This is a map showing all of the countries who recruited patients for the study. The darker the color, the more patients that were recruited. You can see India, China, the United States recruited a lot of patients. But importantly, nearly every single country in the world is represented here. In the end, we recruited more than 4,000 patients from 150 countries, more than 200 referral centers. We think represents well more than 50% of all of the retinoblastoma in the world. And it showed us what we knew, but in very statistical terms. Unfortunately, it showed us, I'll just go over these graphs briefly, that children from low-income countries presented much later in life than children from high-income countries. And it's not that the disease is happening later, it's that they are not even making it to the hospital for about a year longer. Unfortunately, that translates to what the disease looks like. And as you've heard, when retinoblastoma is inside of the eye, we can usually cure it, save the child. When retinoblastoma is outside of the eye, it becomes very hard to save the child. And you can see here in low-income countries, the rate of retinoblastoma outside of the eye is very high, about 50%, whereas in high-income countries, that rate is about 1%. Well, this we knew, but I want to highlight something very important from this study, and that is we asked each of these 200-plus centers in the world to tell us what modalities or what treatment options they had available in their center. And I want to highlight one of them. One of them here is the presence or the ability to provide systemic chemotherapy. 98% of hospitals in the world could provide systemic chemotherapy. Now, when I go and I talk in the United States and other places, we talk about various different treatments that are available. It's a little bit better here, a little bit better there. The important thing is to save lives, you just need systemic chemotherapy, and 98% of hospitals have systemic chemotherapy. We're going to come back to that point. So we followed these patients for 3 years, and I know this slide is awful because nobody can see the names of the countries here, but that's because there are so many. So for 3 years we followed these patients, and recently we looked at the analysis of the outcomes of these patients from 2017 until 2020. And we looked specifically at the continent of Africa. And this is information that just came out and was published a couple of months ago. So we have about 1,000 patients from 41 countries and about 66 centers on the continent of Africa. And the most important thing we learn from this data is this graph. And that is, on the far left, we're looking at the survival of patients who are diagnosed with retinoblastoma on the African continent. You can see on the far left, we're at 100% when the kids present to the hospital because everybody is still alive. But over time, that curve drops. And that curve, unfortunately, drops more than any other continent. But it doesn't drop perhaps as much as we all had thought. On the continent of Africa, about 2/3 of patients are still alive at 3 to 4 years after diagnosis in this paper that we just published a couple months ago. That's a little bit better than maybe we would have expected. You've heard today from a number of centers who have been developing great treatment programs in their countries. A lot of these African countries have fantastic world-class treatment centers, and the treatment that children are receiving is very, very good. That is the second point we're going to come back to. One other brief analysis. We looked at these data in an interesting way. We tried to figure out if the number of children with retinoblastoma in the world is increasing. And we looked for this part of the analysis at the continent of Europe. And the reason we looked at Europe is because in Europe, they have very regimented cancer registries. So we know from many of the European countries exactly the number of patients that had retinoblastoma from that country. And when we looked at Europe, we found something very interesting, which is visible here in this graph. And that is that when the number of patients presenting in a country come from a place where the percentage of families with retinoblastoma is higher, then the overall incidence of retinoblastoma is higher. Let me say that a different way. When you have a lot of families in a country who have retinoblastoma survivors who are having more children, that country has a higher rate of retinoblastoma than other countries. And that makes sense because at the baseline, there's going to be a baseline number of mutations, of problems that happen in newborn children that produce retinoblastoma. But when patients who are survivors are having more children, you're going to add to the number of total kids who have retinoblastoma. I wouldn't call this a problem, I would call this a great opportunity. What this means is that retinoblastoma survivors are becoming so confident in the treatments in these high-income countries like Europe that they're having more confidence in having children with retinoblastoma. So here on this graph you can see where there are more families having children with retinoblastoma, there is a higher incidence of retinoblastoma. Now let's tie all of these three things together. I've said three things, and now I'm going to paint you the picture of retinoblastoma in Africa. Fact number one, low-income countries, and when we say low-income countries, we're mostly speaking about Africa. 23 of the 26 low-income countries in the world are in sub-Saharan Africa. Low-income countries have access to life-saving treatment. Perhaps we didn't realize that. Systemic chemotherapy, or chemotherapy through the IV, is available in the vast majority of hospitals across the world. Fact number two, 2/3 of children in Africa with retinoblastoma are surviving. So as our centers in Africa become more and more able to provide chemotherapy to more and more patients, the number of patients surviving is going to increase. When you have an improved outcome on the continent of Africa, then you're going to have this new challenge. Again, not a problem, but a challenge. And the challenge is, as the outcomes of retinoblastoma in Africa improve, the number of children with retinoblastoma in Africa is going to skyrocket. And the reason for that is because Africa is very different than the rest of the world based on this map. What this map shows is the fertility rate by country across the globe. So we know in Europe that the incidence is increasing with their low fertility rates. The fertility rates in Africa are 4 to 6 times higher than those fertility rates of Europe and North America. So as these treatment centers come online and produce and provide very good treatments, and our number of children with retinoblastoma survive, they will then become confident survivors, and they will have children, but at this rate, not at the rate of Europe. So the global burden of retinoblastoma has two important arms. The first is the unfortunate truth that we all know, that the majority of patients that are dying of retinoblastoma are unfortunately dying in Africa. But the second, very different arm, but also a very important arm, is that as the care of retinoblastoma in low-income countries and Africa improves, the volume and the burden of the disease will increase. These are two additional patients from our 2017 study. I apologize for how brutal they appear, but they are real patients. There are many things that we can all do to prepare for this, but I think it's just important that we all recognize that there's a burgeoning problem, burgeoning opportunity in the continent of Africa. In Seattle, we're doing a lot of things to try and address that. I know many people in this room and all around are doing a lot to address that. I want to thank everybody in my lab who's participated in this. That's Didi Fabian. You heard from him already. He's a big part of many of these studies. In Seattle, we're doing a lot to try to address the genetic diagnosis of retinoblastoma to help these people know if they are at risk of having children with retinoblastoma. That's hard because it's very time-consuming and very expensive, but we're developing some cheaper options to try and provide that opportunity to people more broadly. If you would like to participate in our research, we would love to have you participate. I could even get your information here and even meet you and enroll you in our participation studies here. So if you have any interest and you are an RB survivor, come and talk to me afterwards. Thank you so much.
Hello? Yes, you can hear me. Thank you very much, Andrew, for that very eye-opening presentation. I wasn't able, unfortunately, I wasn't able to control time for especially those who were, had pre-recorded talks, but I think it was worth it listening to them. So we only have about just over 5 minutes for questions. Do we have any questions online? If we do, I think we've got the mics here as we did yesterday. We might be able to listen to have about 2 or 3 questions. Yes.
Hi, thank you very much. I think this session was excellent. I'm really happy with how much Ghana has done so far, and thank you for presenting that. I think Ghana really leads the world in the way that you're trying to manage retinoblastoma with the targets and all of that. I think the maturity level at which you're approaching something like that is something that's inspirational, and I hope the whole world learns from you. I think my question is actually for Andrew's talk in the end. I think yes, you're absolutely right in that having people survive retinoblastoma is obviously something that we all want for everybody in the world, of course. And linking that to the fertility rate is something that is also important. I think if you look at countries like India, where the fertility rate is not so high, but was so high in, let's say, the 70s, you'll start to notice that perhaps the fertility rate will come down with improvement in healthcare and with improvement in everything else. And I'm not sure that I share the predictions in the same way that you do. I don't think the fertility rate will remain 6. I think the fertility rate may come down, may not be as low as 1 or 1.5 that it is in let's say, lots of European countries, but a fertility rate of 2 means the population is not growing. And India is perhaps reaching that population, that sort of a plateau in 2030 or 2050 or something like that that's expected. I'm assuming that all countries will go in that direction. And I don't really think the fertility rate will remain that way. So I don't think that mathematic will hold in about 10 or 20 years to come. And I don't know what you think about that, or the others in Africa think about that. So I'd like to know what the panel thinks.
Check, check. I would defer that question to the doctor from Africa. I think you're probably very right, but I'm not sure either. What do you think?
Yeah, I think it's going to be a balance between the two. I think I really agree that once the improvements in health services and people are not losing their children, which they're not losing as they were before, under 5 mortality has gone down from about 120 per 1,000 live births. Now in Ghana, it's about 40 per 1,000 live births. So there isn't really that need to have so many children. So hopefully, there may be not such an exponential increase in retinoblastoma, incidence, but we can't tell.
Yeah, I would also add that fertility rate, we're looking at it on a nationwide level, but we know there's regional differences as well. And there's also regional differences in who presents earlier versus later. And the unfortunate truth right now is those further away in those more rural populations where there's higher birth rates are also the ones getting to the hospital late, and their children are not going to be the first ones that we're going to be able to treat with our available methods. So there's a lot of little nuances there. Yeah.
Yes.
Hello, thank you very much for the beautiful presentation. I am Maria Manquez, ocular oncologist from Chile. I was trained at Wilside by Dr. Carol Shields, and those years we had the RedCam there, of course, at Wilside. But when I came back to my country, we did not have RedCam in Chile. So what we used is the device that you have for surgical removal, for gallbladder removal, that is present in every large hospital. And we use the proof that you have with light and optic, and we apply over the eye globe with jelly. And in that way, we can have the images for showing the parents, the doctors, and also for raising money and for credibility regarding what we were doing. The images are not as beautiful as the RedCam, but it works. And I do really recommend, because it's a device that you have in every hospital as systemic chemotherapy. And also, you have to use it with video mode, not the photos. And it's practical. You have the record, and you don't have to pay much more money for a new RedCam. Thank you.
Thank you very much for that. Good.
Thank you so much, everyone. We appreciate your time today.
And hi to Ermias and online, because they're there. Great. Okay, are we done?
Yeah. Any question online? No. I think otherwise
No,
time
we
is,
have
yeah,
we
our
have
time
ended
is,
the virtual.
Our time is up. And you
Thank
can speak to the speakers during the break time if you have anything else pressing. Thank you very much.
Great.